Okay. Assuming you can all hear me, I'm happy to start as we're a bit limited for time. So perineal disorders. Okay. Not advancing. There we go. So just a quick revision on the anatomy of the perineal tendons. Let me just admit all of these folks to the waiting room. Invite, fantastic. The perineal tendons are on the lateral side of the ankle, and they arise from the perineal muscle group, which are located in the lateral compartment of the lower leg. The two muscles are called peroneus longus and peroneus brevis, which is situated anterior and slightly more medial to peroneus longus. And in cross-section, they're identified by the peroneus brevis muscle belly being continuous a little bit lower down than the peroneus longus muscle belly. The two tendons share a common synovial sheath up until the point of the inferior perineal retinaculum, where they divide and the tendons pass onwards to their insertions. So the peroneus longus is obviously more tubular and more tendon-like, and as you go distally in the ankle, the peroneus brevis tendon flattens out to lie anterior to the peroneus longus tendon in the fibular groove. Now, the fibular groove is quite an interesting space. It's very tight and it's very limited. The two tendons lie in close proximity to one another, covered by the superior perineal retinaculum, which attaches to the periosteum on the outside of the fibula. And the groove behind the fibula is deepened by a fibrocartilaginous rim, much like the acetabular labrum. And this functions to keep the perineal tendons in place. The base of the fibular groove is coated with something almost akin to hyaline-like cartilage, so it's very smooth to reduce friction between the peroneus brevis tendon and the back of the fibula. So this is quite a limited space, and what we know is anything that causes swelling, such as perineal tendinopathy, or indeed any of the anatomical variants that we may find, can cause patients to develop perineal tendon symptoms. Now, what we know from cadaveric anatomical studies is that 1 in 20 patients without pain have a peroneus cautious tendon. So this is a vestigial tendon, a bit like the appendix. It's completely useless, but can cause you problems. This tendon is highly associated with the development of perineal tendinopathy. As you progress further distally into the midfoot, the perineal tendons divide from their common synovial sheath into two separate tendons visible at the level of the perineal tubercle. So this is a little bump on the outside of the calcaneum where the inferior perineal retinaculum is attached. This in itself can become prominent and hypertrophic in very active athletic individuals, and in thin patients can cause rubbing inside footwear. And this is associated with the presence of an Ospronium within the peroneus longus tendon. So what is an Ospronium? It's a little bone, or can be bipartite, can be two separate pieces of bone, which are a bit like the patella in the patella tendon. They are beneficial in some respects by increasing the lever arm of the peroneus longus tendon as it passes underneath the cuboid, shown by the red arrow. But in a great number of patients, they cause pain on the lateral side of the forefoot as they pass through what is quite a narrow gap. So the cuboid tunnel through which the peroneus longus tendon runs can be an area of constriction, and patients can develop lateral forefoot pain as a result of a stenosing tenosynovitis. And in these patients, we often require footwear modification, attention to running surfaces, perhaps an insole, or even an image-guided injection to settle down inflammation in that area. A little bit more on the anatomy and what happens in the forefoot. The peroneus longus tendon slingshots underneath the cuboid through the cuboid tunnel and attaches to the base of the first metatarsal and medial cuneiform. And in this way, it's a powerful plantar flexor and inverter of the foot. It is overactive or relatively overactive in a neurological pes cavus, and you can see from the photo how it will plantar flex the first metatarsal and cause an excessively high arched foot. The peroneus brevis tendon is more of a pure everter and plantar flexor and attaches to the base of the fifth metatarsal. Both tendons act a little bit like horses' reins. They give the ankle stance phase stability, and through the insertion of the peroneus longus tendon on the first metatarsal plantar base, it acts as a midfoot transverse arch stabilizer. When they're acutely injured, patients present very much like lateral ankle sprains. The mechanism is slightly different in that they injure these tendons through dorsiflexion and forced inversion, whereas your typical Pott's ankle fracture or ankle sprain is through plantar flexion and inversion. They are felt to be as common as 1 in 20 of all ankle injuries, and up to 3/4 of all lateral ankle instability patients have some form of perineal tendinopathy. So they're very much involved in lateral ankle stability. And of course, when you see patients with these injuries, the differential diagnosis includes low fibular fractures. So a bit of advice there to have a low threshold for X-raying, particularly if they have malleolar tenderness, difficulty weight bearing. Not forgetting also that the peroneus brevis, through its insertion on the fifth metatarsal base, can cause an avulsion type fracture. So look there as well. In scrutinizing X-rays in much more detail, you may see very subtle signs of a superior perineal retinacular injury. So you can see from these blue circles, so how do I go back? You can see from the blue circles that you see a small flake of bone reflecting where the superior perineal retinaculum has avulsed its attachment from the fibula. And in these patients, you may see further on down the line, than when most of their bruising and swelling has settled, the problem of perineal tendon subluxation or even dislocation. Patients here present with lateral ankle pain of varying severity and can voluntarily dislocate the tendons from behind the lateral malleolus. MRI is a very useful investigation for these patients. It will enable you to see the morphological characteristics of the back of the fibula. So whether or not the fibular groove is sufficiently concave to contain the tendons, and whether or not there's been an injury of the superior perineal retinaculum, as you see here. So like everything in orthopedics, we like to grade and stage everything. The usefulness of this classification is debatable, but the grades of severity range from a type 1 injury where you tear off the superior perineal retinaculum from the fibula, and the fibrocartilaginous rim remains intact, through to an injury, complete or incomplete, of the fibrocartilaginous rim, allowing the perineal tendons to escape from behind the fibula, but where the superficial perineal retinaculum remains intact, sorry, the superior perineal retinaculum remains intact, or a type 4 injury where you don't see the injury on the side of the fibula, but it's avulsed from its distal attachment on the calcaneum. Ultrasound, particularly dynamic ultrasound, is a very useful investigation to demonstrate not only tendinopathy through Doppler examination. So you'd ask your radiologist to look for increased blood flow reflecting inflammation around the peroneal tendons and synovitis, but they may also be able to show you the peroneal tendons changing position with foot position. So so if you follow the diagrams with me, on the far left, A and B is the normal position with the peroneus brevis lying in front of the peroneus longus tendon. Type 1 Rakin classification is where the peroneus longus tendon swaps position with the peroneus brevis tendon. And type 2 Rakin injury is where there's actually a split in the peroneus brevis tendon, allowing the peroneus longus tendon to flip through to the front. Again, an interesting classification, but probably of limited utility in terms of how you're going to manage the patients. And of course, how you're going to manage any acute lateral ankle injury is with rest, ice, compression, and elevation, which will allow you to then arrange your detailed imaging, be it ultrasound or cross-sectional imaging. Whether or not you continue non-operative treatment or refer for surgery really depends on what those imaging findings are. So if you have a stable and reducible tendon dislocation in a low demand, non-professional athlete, perhaps you will choose to cast them for 6 weeks and keep them partial weight bearing. And the position you cast them in is one of plantar flexion and inversion. You may decide that if there's just perineal tendinopathy or perhaps minor intra-sheath subluxation, a boot and activity modification is enough. What's important is that you allow the patient to have complete resolution of their symptoms before they recommence exercise. The main contraindication to both of these treatment modalities would be a perineal tendon tear that's of any significant size. And of course, in patients who have had instability in the perineal tendons for some time, perhaps more than 6 to 8 weeks, the usefulness of immobilizing them and hoping that their perineal tendons will then stabilize is debatable. The literature quotes a 50% at least failure rate in chronic instability patients when they're managed non-operatively. Perineal tendon tears have been classified according to David Redfern and Mark Myerson. A type 1 injury is a small tear, most of the tendons intact, usually just of one tendon. So the treatment that we would perform would be operative treatment comprising tendon debridement and tubularization. If a tendon is completely torn, particularly if one end is retracted, provided you have one tendon that's still useful, you can undertake an operation called a tenodesis. So this involves taking the torn end of the torn proximal end of the tendon and stitching it to the intact distal tendon that has not been injured. The greater severity of injury means more invasive surgery, and so if you've got both tendons that have been torn, you can't perform a tenodesis. You would need to undertake some form of interposition tendon graft, and that's only if your muscle bellies have sufficient excursion. So really the message here is if you find a perineal tendon tear, early referral is the key. Otherwise, there's a risk in condemning patients to more invasive treatment with probably less predictable outcome. And in undertaking surgery to the perineal tendons, cross-sectional imaging beforehand is very useful because it will allow us to determine whether or not we need to perform additional stabilization procedures. In patients who have a shallow fibular groove, we'll undertake a groove deepening procedure, and there's a couple of different ways that this can be performed. One is by undertaking a saw cut along the fibula and hollowing out the bone underneath using a small burr, and then tamping down the fibrocartilaginous gutter, and then preparing the superficial perineal retinaculum. Sorry, I keep saying superficial. I mean the superior perineal retinaculum. Or my preferred technique, which is using a drill to hollow out the fibula from beneath and tamping down the fibular groove. Fibular osteotomy is a historic technique, is used for recurrent perineal tendon dislocations when you perhaps tried the hollowing out of the fibular groove. The outcomes are really pretty good for this procedure. The literature quotes 90 to 100% of patients returning to sport within 12 weeks if superior perineal retinacular repair is combined with a groove deepening. In patients who have chronic tendinopathy, so this is moving on from the acutely injured patient, we know they present with reduced exercise tolerance, lateral ankle pain, and perhaps some swelling. But the key here is the tendon findings themselves. Do they have pain on passive stretch of the tendon? So if they have reproducible symptoms with plantar flexion and inversion, that's very reliable for perineal tendon related pain. The compression test is where you apply pressure to the tendons in the fibular groove and cycle the patient's ankle through plantar flexion and dorsiflexion, and at this point you may feel tendon crepitus as the tendon moves in the groove. And of course, as part of your tendon examination, you're going to undertake an ankle stability examination, so your anterior drawn hindfoot inversion signs, given that we know almost 3/4 of patients with perineal tendinopathy have ankle instability. As part of the assessment, it's useful to perform some form of analysis of patients' gait and proprioception. So I get them to stand on one leg and I'm looking at their ability to recover from an uneven balance and looking at the perineal tendons firing. And also I'm going to look at hindfoot deformity. So a significant number of patients have hindfoot varus or even a degree of cavus to the forefoot. And what this test is showing, the Coleman block test, is the correctability of the hindfoot deformity. So if they have a cavus foot where the hindfoot varus is driven by the plantar flexed first metatarsal, the block being placed under the lateral border of the foot and the heel, allowing the first metatarsal to drop off the block, will show the hindfoot correcting into neutral or a few degrees of valgus. And really the findings can be the hindfoot fully corrects, in which case a laterally posted insole can be enough with some relief under the first metatarsal head. Surgically, the equivalent is a dorsiflexion osteotomy through the first metatarsal. If the hindfoot partially corrects, you're going to probably combine your first metatarsal osteotomy with a lateralizing calcaneal osteotomy. But if after performing this test and examining the patient's hindfoot mobility through the subtalar joint, they've got evident hindfoot stiffness, you're going to be more likely to perform an arthrodesis of the subtalar joint, and that's a corrective arthrodesis to bring the hindfoot back into its physiological valgus. A significant proportion of patients have gastrocnemius tightness, and this has a bit of a whipping effect to the hindfoot. So if you can imagine a runner impacting the pavement for several thousand steps, a tight gastroc, which is swinging the hindfoot into varus, is going to have a significant tensile effect on on the perineal tendons. So what this test is showing is whether or not the Achilles tendon is causing the tightness, or whether or not it's the gastrocnemius muscle itself. So given the gastrocnemius muscle has its origin above the knee joint, when the knee's fully extended, you're examining both gastroc and soleus tightness, and by bending the knee, you're taking the gastrocnemius muscle out of the equation and examining for additional ankle dorsiflexion. And if you obtain more than 10 to 15 degrees of additional ankle dorsiflexion with the knee flexed, you can say that the gastrocnemius muscle is causing the tightness. Obviously, you need to assess the patient's perineal tendons. So here what's going on is I'm positioning the patient's ankle in neutral, and I'm asking the patient to hold their ankle against my hands, so that I'm testing the eversion strength of their perineal tendons. And undoubtedly, some dedicated physiotherapy using a TheraBand can help strengthen up the perineal tendons in patients who have a degree of weakness. So why are we doing this talk anyway? Well, I think the management of patients with perineal tendinopathy is a good example of how cross-specialty management can be tremendously beneficial. Much of these patients do resolve with dedicated physio, so perhaps some bracing or taping, some strength training directed at the perineal tendons, some eccentric gastrocnemius stretches, and working on the patient's proprioception using wobble boards. It's important to look at patients' footwear. Increasingly, we see patients going to running shops and buying overpronation trainers. So they're told to go on the treadmill and told that they're overpronators. Of course, pronation is a natural foot movement. You need to pronate your foot in order to toe off. But if a patient has been given overpronation trainers and they already have a degree of hindfoot varus, this is just going to drive the ankle over into more varus and make their perineal tendinopathy much worse. And the same is true for insoles. Many off-the-shelf insoles have medial hindfoot posting, a relatively stiff arch support, and that's just going to do the same thing. That's going to drive them over, make their perineal tendinopathy much worse. Worthwhile educating runners about their running technique. If they're running on certain sides of the road with a camber in the road directed one way to the painful ankle, then that's going to drive them over. So running on the other side of the road can even be beneficial. And of course, avoiding uneven or soft ground, which is just going to accentuate the pull on the perineal tendons. Is there any evidence for injections in the management of tendon tears? Well, the short answer is no. There have been small series looking at platelet-rich plasma. There's no large-scale randomized controlled trials looking at this, and certainly steroids have no role in the management of tendon tears, and in fact can risk tearing the tendon completely, or basically giving an anabolic substance which is going to completely stop the biology of healing. Tendoscopy has emerged as a technique for managing small tears, perhaps synovitis around the perineal tendons. There's a technique popularized by Nick van Dijk from Amsterdam, which he calls adhesiolysis of the vinculae. Just looking at what this is, the vinculae are small synovial strands which transmit blood vessels to the tendons, and probably those little blood vessels transmit very tiny nerve endings, and so removing them can improve pain, and you can remove scarring with arthroscopy. But The procedure which Nick Van Dyke originally looked at, which was deepening of the fibular groove arthroscopically. The last time I watched his talk, he said that he had abandoned this technique, and reverted to the open technique for fibular groove deepening. So tendoscopy, perhaps very useful in the early stages of tendonitis, but not for more significant disease where there's tendon dislocation and large tears. So in summary, what we said is that perineal disorders aren't always a disorder in isolation. A large proportion of patients with perineal tendinopathy have lateral ankle instability, so it's important to look for that. If patients after their imaging have perineal tendon tears, they should be referred early, because we can do something about it early on, which is perhaps less invasive surgery. By waiting to see if tears get better with non-operative treatment, we're probably risking the patient being condemned to more invasive treatment. But when all of the acute episode has settled and been managed, it's important to look at some of the biomechanical predisposing factors that patients have, such as hindfoot varus, working on their proprioception with wobble boards, strengthening out the gastrocnemius with eccentrics, looking at footwear and running technique. That's really important. And undoubtedly, the best outcomes in managing these often quite active patients come with cross-specialty management. Thank you very much for listening. I'm happy to take questions. We've certainly got a bit of time. So I'm going to open up my chat box. Please unmute yourself if you have a question. Mm. So we've had a question from Athena. Is a tendon tear more common with lateral ankle sprain, high grade? Thanks. So thanks very much for the question, Athena. So the mechanism of injury is ever so slightly different. With pure lateral ankle sprain, the foot is usually in a plantar flexed and inverted position. And the localization of tenderness tends to be anterior and distal to the fibula, but with perineal tendon tears, certainly ones of any significance, the ankle is in a dorsiflexed and inverted position. So the clue is in the mechanism that the patient describes, and I appreciate that's not always very clear. The localization of tenderness with a perineal tendon tear tends to be behind the fibula and a little bit more proximally as well. And the answer is you need always to have a high degree of suspicion with any pain and bruising around that area, and it is more common with lateral ankle sprain. As said, up to the literature suggests anywhere between 23 and 77% of patients with lateral ankle sprain have a perineal tendon condition. May not be a tear, it may be tendinopathy, but it'll or instability. It's very disconcerting because I can't hear anybody. Well, thanks very much, everyone. I'm going to hand over to my colleague, Mr. Lloyd Williams. We'll just get his talk up. And thank you again for your time.
Yeah. Right, I can take it. Ready? Yes. Ready to talk? Hello, everybody. Can you hear me? Can anybody hear me?
Yes, Lloyd, we can hear you.
Great, thanks.
Yeah, we can hear you. Yeah.
Thank you. Great. I'm Lloyd Williams. Some of you may know me. For those of you who don't, I hope you enjoy my lockdown mullet, which is about to be chopped today. I'm going to talk about tibialis posterior insufficiency and flat foot correction. Okay, so tibialis posterior insufficiency, otherwise known as adult acquired flat foot, or more importantly, if you think about the mechanism, lateral peritalar subluxation. In other words, everything subluxes laterally around the talar head, or particularly on the AP view. So what's the anatomy of this tendon? It's a strong tendon, and it curves strongly and tightly behind the medial malleolus within a pretty tight sheath. The sheath is extremely tight behind the medial malleolus, and it gets a bit more roomy below it. It's got a broad origin and a broad insertion originating from the posterior surface of the tibia, the fibula, and the interosseous membrane. And as you can see, it has multiple insertions into the bones of the midfoot, most notably the medial tuberosity of the navicular. It has a short excursion in a sense that it's a strong stabilizing tendon as opposed to the long flexors and extensors, which have a long elastic type excursion. So if you cut it, it doesn't spring too much. So here we are. You can see some anatomists think there's two bands to it, an anterior and a plantar band. And to be honest, I've never seen this in clinical practice, but you can see the root of this from behind down below and into the navicular tuberosity and so on. So what does it do? It stabilizes the hind foot. It keeps your arch up. It acts as a plantar flexor and an inverter, and it's a strong resistor of gravity. In other words, once it becomes damaged or doesn't work, the medial longitudinal arch will collapse. It prevents abduction of the midfoot. Its opponent is peroneus brevis, which acts to evert and dorsiflex. It is much stronger than FDL and FHL, which is important because these are the tendons which are used should you need to do a tendon transfer for an insufficient tib post. What is the pathology of this tendon? Well, it can undergo numerous pathologies leading to stretching out or tear. Essentially, the most common one is someone who's had a long-term pes planus or sometimes pes planovalgus. So the tendon has been under pressure and under strain throughout life. And when people reach their 50s, perhaps gaining weight, it tends to rupture or stretch out somewhat insidiously and often without pain. You can also get rarely an acute rupture in the normal foot. This takes quite a severe injury, and it often could be associated with open fractures and so forth. It can be damaged by screws that are put into the medial malleolus as part of a fixation of an ankle fracture. And also it can be compromised in youth in someone who has an accessory navicular, which tends to irritate the tendon as the tendon overlies and runs over the accessory navicular tendon. Okay. What essentially happens is a synovitis is set up, which can be traumatic, but is usually inflammatory. This sets up a mini compartment syndrome in the tight sheath. And like all tendons, there is a hypovascular zone just at the junction of the retro and inferior malleolar portions. And it's this that can stretch out, stroke, rupture to lead to the problems. So what's the clinical scenario? Firstly, in the early stage, you get medial pain, swelling, and a limp with some warmth and medial tenderness behind and particularly below the medial malleolus. Eventually, the foot will go flat. What will then happen is the heel will drift outwards into valgus and will impinge on the tip of the fibula, causing lateral pain at or just in front of the tip of the fibula. The medial pain may then settle. The midfoot will then abduct, and the medial longitudinal arch will drop further. So here you can see in the early stages, swelling just below and behind the medial malleolus with some redness. And it's very important if you're a GP or a physio in the early stage to pick this up, because this is where you can make a major difference by resting the tendon in a boot, anti-inflammatories, ice, elevation, and maybe even crutches for partial weight bearing. The other findings are a too many toes sign with tenderness behind or below the medial malleolus. And also patient on doing a double heel raise, the heel does not go into varus and the patient cannot single heel raise once the tendon is damaged beyond stage 1. So here you can see this view from the back. You've got on the left side a normal heel alignment. On the right, you can see a too many toes sign. You can see swelling medially where the black arrow is, and also you can see that the vertical line of Achilles tendon alignment is broken. This means that the Achilles tendon is pulling off center and will accentuate the valgus deformity. Again, on the left, you can see a bilateral too many toes sign with the patient in significant trouble. Here you can see probably slightly worse on the right, but a classic bilateral too many toes sign. And on the double heel raise on the right, neither heel swings into valgus. You can see, neither heel swings into varus. My mistake. Okay, what are the secondary features? The Achilles tendon in pushing offline can become tight. The first tarsometatarsal joint in the middle of the mid-longitudinal arch can become painful, it can become unstable, and eventually it can become arthritic. Lesser MTP joint synovitis can then occur. Hallux valgus can occur. The lesser toes can become clawed because there's long flexor overpull. This is because these long flexors try and take up the role of tibialis posterior and try to make the arch more stable. On the outer side of the foot, due to midfoot abduction, the calcanea cuboid joint can become compressed and become painful itself. Further on in the deformity, if you imagine the foot is flat, the forefoot will undergo a supination deformity. So the first metatarsal will go high if you correct the heel from its valgus position. And this can be mobile or fixed. If it's fixed, it needs surgery, which I'll come to shortly. So the stages, there are 4 stages. Stage 1 is an intact tendon with tenosynovitis, pain, and medial swelling. Stage 2 is a failed tendon with a flat foot deformity, which is flexible and correctable by hand. Stage 3 is a fixed flat foot with hindfoot degeneration. And stage 4 is when the ankle goes into valgus also. Some people feel that the ankle valgus stage 4, is actually a primary problem related to complete failure of the medial longitudinal ligament. And there's some argument about that. I'll leave that slide. Whoops. Oh, I need to go back. Okay, it's imaging. MRI is good for splits and Athena Synovitis, and also to look at the Achilles, also to look at the joints to see if there's any degenerative change. Ultrasound is fantastic for tendons, as you probably all know, in that it's dynamic, and it's also very good for splits and Athena Synovitis. In the assessment of tibialis posterior problems, plain x-rays are only applicable when there's a deformity, and these should always be done standing. We need a standing lateral view with a whole foot, and also we do a Kobe view, or now a modified Saltzman view, which is used from the back of the heel to show the hind foot alignment, which we'll see shortly. This is an MRI of the ankle, and you can see on the medial side where the arrow is a large, slightly swollen, but essentially intact tibialis posterior with a large effusion around it. This is an MRI of a ruptured tibialis posterior tendon, which is completely gone. You can see behind it, the small black dot is the FDL, and further back is the FHL, Achilles right at the back. X-rays, what do you look for on X-rays? On the AP view, you look for talar navicular subluxation. You look to see if the navicular's gone way off laterally. On the lateral standing view, you can get sagging through any of the 3 levels of midfoot joints or combined. You also look for ankle deformity. And on the lateral view, you look at the talo first metatarsal angle of Meary, where basically you draw a line right through the talus, right through the first metatarsal, and that should be a straight line without any angulation if it's normal. So here we are, you can see an accessory navicular here on the medial side of the foot, and over that runs the tibialis posterior, and that's a potent cause of irritation and dysfunction of the tendon. Moving on, you can see marked midfoot abduction. On the right side, you can see that this angle is meant to be 0 because that's meant to be a straight line from the first metatarsal down the talar head, but it's not. You can see again on the left talar navicular subluxation, and you can see on the lateral side that the calcanea cuboid joint is under pressure. Moving on the right view, you can see the talonavicular line of Meary is broken, and there's also some sagging through the first tarso-metatarsal joint with that upside down angle there. This is a gentle sag at the top. This is not a very gentle sag at the bottom with complete talonavicular collapse, as you can see. This is stage 4. If you look at the view on the left, you can see a congruent ankle joint. On the right, you've got a horrible valgus ankle, bone on bone, and you've even developed further up a lateral fibular stress fracture. The Kobe view is a bilateral hindfoot alignment view. I won't trouble you with the technical radiographic details, but basically here it is. These nails are not part of the patient. They're in the board that the patient's standing on, and you can see that both of the heels are very valgus, such that if you drew a line straight up the middle of the calcaneum, it would be going pretty much up the fibula rather than up the tibia. So that means that the lateral weight bearing is shifted laterally. And you can see on the next view, this patient has had a calcaneal osteotomy. You can see 2 screws, and you can see that the heel alignment is much more natural now with just a few degrees of natural valgus. Conservative management. Stage 1. Rest. You can use a reversed air cast brace, or we have now posterior tibialis tendon deficiency braces, which can increase your arch. Possibly an air cast boot would be helpful with an insole inside. Anti-inflammatories, gentle physiotherapy to calm everything down, and a medial arch support. You can do injections, but I asked my radiologist to do an ultrasound scan, and I put quite clearly on the form, please inject if no split. If there's a split, you don't inject, you make it worse. You can do a debridement and synovectomy and cleaning up the tendon, and hopefully that will work. This can be done open or tendoscopically, as Lee mentioned. And sometimes, rarely, you can do a single repair of a small split in the tendon if it's still working. We often don't see that to be the case. They normally go from stage 1 straight to stage 2. This is Athena Synovitis. You can see quite a lot of inflammation around the tendon here, and this is a candidate for surgical debridement and generally tidying up, but that's quite rare. Stage 2 is a major source of problems, and there's quite a spectrum of disorders within it. Conservative treatment can be with orthotics. They must be customized. They need a strong medial longitudinal arch support. And I like to give both forefoot and hindfoot medial wedge posting. In other words, you need some height under the medial side of the heel. And most commonly, you need some height under the medial side of the forefoot also. And some heel cup control is desirable. So you need one on, like the black one on the left, with plenty of arch support there. But normally, if a patient is relatively young, and I mean under 70 or even over 70, if they're fit and well, we're looking at reconstructive surgery. So what do we do when we do surgery? This is an example of a badly damaged, useless tibialis posterior tendon. It's still intact, but it's ripped to shreds and it won't be working. And that is not repairable, that you have to do a reconstruction. So the workhorse of surgical treatment is to get the heel bone back under the tibia, and we do that by a medial displacement calcaneal osteotomy. That is a push me, and then you need a pull you, which is the FDL transfer. We use the flexor digitorum longus tendon and we plug it into the navicular at the point of action of the tibialis posterior. That is the basic workhorse of this treatment. You may also need to do a lateral column lengthening. If the navicular has drifted off laterally more than 40% of the covering of the talar head, you can do a distraction of the calcaneal cuboid joint. I'll come to that shortly. I'm just going to show you some operative slides now. This is a patient in the lateral position. You make a lateral incision over the heel, and we make an osteotomy, and we shove the back part of the heel attached to the Achilles as medial as possible. You can see that's quite a push there, good ½ inch worth, and we fix it with a screw or two from the back. All right. I tend to do this minimally invasively now through a tiny incision, and we get the same result, which is really great. This is an axial view of the heel. You can see how much push there's been medially. So that is enough to give you good correction of your abnormal Achilles tendon pull. As I say, I'm now doing this with a minimally invasive burr system, which is technically safe and easy. We then roll the patient supine, and then we address the problem on the medial side. This is a bit more complex. So there you can see quite a long incision. There's the tibialis posterior, which is badly damaged. I've excised the tibialis posterior. You can see the stump of it. Not only is it useless, but it's often painful, so you can remove it. It's not there, not necessary anymore. You can see the FDL identified. We chase it down to the knot of Henry, where it crosses the FHL, and you can see the FHL just deep to it. It's quite a big incision. We harvest it. We then do a repair of the spring ligament with a medial capsular flap, because if you imagine that the talar head has gone medial, or the structures around the talus have gone lateral, the spring ligament will have been stretched out, stroke torn medially by the talar head pushing against it. So we chop out the diseased part of the spring ligament and we repair it. We make a drill hole in the navicular, pass the tendon through. You can just see it there on a bit of string. And we then do a tightening up of the spring ligament with some non-absorptive sutures. And finally, we pass the FDL tendon right across and suture it up with the foot held inverted and slightly plantar flexed, thus resting it. So you can see there's a lot of ethibond there, so you need to cover that well. And plaster for 6 weeks, 2 weeks of which is non-weight bearing, then an air cast boot. It takes about 9 months to get over it all. You may need to add in lateral column lengthening, which can be done with a fusion with biofoam wedges or a lengthening osteotomy. You can see this on the lateral side here. This brings the navicular back round onto the talus by pushing it around medially. So you can do it either by fusing the calcaneal cuboid joint with a block in it, or you can do it with a block of bone into the distal part of the calcaneum and fix it with a plate like so. But you've got to be careful with that plate because it can rub on the perineals and give Lee some work. There you can see a calcaneal osteotomy, a lengthening calcaneal osteotomy, and the staple on the top is something else, which I'll come back to in a moment. There you can see an old-fashioned slide showing the block lengthening the calcaneum with the navicular beautifully brought back onto the talus. These are some wedges that you can use. Instead of chopping a massive bit out of the iliac crest, we now have these titanium cancellous wedges which allow bone to grow into them, so you don't have to make a nasty hole in the iliac crest. This is an old-fashioned operation called the Cob Transfer, which I don't think is done much anymore. I did do a few. I'm just going to show you it because it's a massive dissection. That's the aim of it, is to bring half of tibialis anterior through the stump of tibialis posterior. It's good physiologically, but the dissection is massive, and it looks as if a pit bull terrier has been at it, frankly. So I don't think many of the punters do this much anymore. You can just see just how big the dissection is, and there's tibialis, the split half of tibialis anterior going from right to left, going on to tibialis posterior. The problem, one of the problems with this is sometimes tibialis posterior is so retracted, you've only got muscle left, so you can't do it. There you can see it's quite a big old deal. I haven't done it for 10 years or so because I do the other technique, and I think virtually all of us do that now. If you have a fixed midfoot supination, it may be a pure supination, or it may be because the first TMT joint is unstable. You may need, therefore, to do a cotton osteotomy with this staple on the top, where you make a cut in the medial cuneiform and open it up, thus pushing the first metatarsal down, and then put a block of bone in or a wedge and fix it with a staple. That recreates your arch beautifully. Or you might need to do a lapidus fusion for an unstable first TMT joint, which will recreate your arch beautifully. And here's one we did earlier with quite a bit of action going on there. Calcaneal osteotomy and a lapidus. There are two further stages. Stage 3 is the fixed valgus hindfoot. You often see old ladies walking down the road with a shopping trolley. They all seem to have a fixed valgus hindfoot. I think it probably goes with the territory. They have to have very strong orthotics in the form of a UCBL type hindfoot cup, or the only surgery for them is a triple fusion, which is fine, but it's very stiffening and a big old deal. Triple fusion being subtalar, calcaneal cuboid, and talar navicular. So there's your strong hindfoot cup with big heel control. Does work. Triple fusion can be done through the standard approach, but I tend to do now just a medial approach for the subtalar and talar naviculars only. I don't tend to do the calcaneal cuboid at all, and you may need to lengthen the Achilles tendon. This is a nice triple. You can see all of those joints have been fused there with good correction. Stage 4 is a horrible deformity. You can treat it with an articulated ankle-foot orthosis, which you really don't see much of these days. We tend to go for surgery where we fuse the ankle and the subtalar joint with what's called a TTC fusion nail. It's called a Valor nail, and there you can see a rod that's been passed up through a small incision in the heel. We've got to beware the lateral plantar nerve because it can get damaged. Got to beware the plantar fascia, and you lock it above and below so that it's good for the elderly, but it's not. You can see it's pretty bad for long-term function. So that's all I've got to say. Do we have any questions, please? Get the questions up. From Afsana, from Sarah, and sorry, those are old ones. Do we have any questions, please? I've confused everybody. Okay. All right. Okay. Okay, thank you. If there are no questions, we'll wrap up here. And I'd like to say thank you for all attending. It's very kind of you to give up your lunch times. CPD points are available. The next event is Orthobiologics. Current state of play on Thursday, the 3rd of June at 12:30. And the talks are provided by Dean Halfpenny and Mark Webb. So please, this is cutting edge stuff, Orthobiologics. So please feel free to join us for those talks. Thank you very much for joining us. Thank you.
Thank you.